welcome to Health Issues. I'm your host, Chris Sylvain, and always excited, but particularly excited about today and the show that we have. And today we have a great guest for you. He in fact, he is the co-chair of the Health Disparities Conference and the director of the Health Disparities Center at Xavier University College of Pharmacy, Dr. Daniel Sarpong. How are you today, sir?
I'm doing extremely well, and thanks for having me.
Well, we're excited to have you. What we're here to talk about, health disparities particularly, but there's a conference, and it's the 9th conference, February the 29th to March 2nd, that will be coming up at Xavier University. No, where is it?
Xavier is hosting it, but it's going to be at the Sheraton on Canal.
Sheraton on Canal.
Right.
And it's a powerful conference. The theme this year is from disparity to equity. But so give us some background about what is this conference, how did it come about, and kind of where are we going with it?
So Xavier University was funded in 2002 by NIH through an endowment fund to really begin to look at research and education as it pertains to health disparities, as an effort to try and mitigate all the health disparity issues that this nation has been faced with. One of the core goals of the center was in the area of education. And so the conference became an integral part of the mission of the center, because the center felt that with the conference, you would be able to bring together people who are in the field, both researchers, practitioners, who are doing some very innovative things to address health disparities. So the conference became the vehicle by which we could bring all these experts, also involve the community to come in and have an exchange of what is working, what are still some of the pressing issues, and how we can collectively as a body get into the work of trying to mitigate health disparities. So it started off in that vein, and every year we've sort of looked at, given the feedback from previous attendees, what the next year's theme should be. And so we've sort of moved more from trying to still focus on disparity, sort of moving more in the direction of how do we achieve health equity. Because sometimes when you dwell on the problem, all you do see is the problem. So this is a way that we are transitioning from how we can move to the problem to the solution, so that every American will be assured of the best health in essence, and build healthy communities.
I think that's powerful. We know we've had Dr. Kathleen Kennedy on, the dean of the College of Pharmacy, and definitely I know Dr. Norman Francis, who we esteem so much, also was there right after he announced his retirement last year. So, and then for yourself, I think it's an awesome team at Xavier, powerful brain trust to bring this thing about, to address the fact that the issues in the African American community, particularly concerning health, that there are huge differences.
Right.
Is that what you're finding year after year? Are we moving forward, or are you trending those things, looking at those things?
Well, I think if we look at the nation collectively, I think we've made some great strides. In 1985, the then Secretary Hegler of the DHHS commissioned a task force to really study, to look at the issues of minority and black health in this nation. That landmark report, which was called the Hegler Report, indicated all the disparities, and that became the national blueprint to begin to address health disparities. Since then, we've made some great progress. Some of the quotes by some of the leading people, both in government and private sector, have said that we've made some great strides in terms of addressing health disparities, but we haven't gotten to where we need to go as a nation. So definitely there is still more work to be done. There's been significant improvement, but we're not there yet. So we're hoping that with these kinds of forums, we can bring brains together and begin to look at how do we move from disparities to health equity and build healthier communities.
Define health equity. I think that needs to be.
Health equity means that people begin to get what you would call the optimum health. It doesn't mean that everybody gets the same thing, but people get what they need to do to be able to optimize their health. So what you may get that may ensure that you have improved health care, better care, may be very different from me because my needs may be slightly different. So sometimes people confuse equity with equality. It's not saying that everybody should get the same thing because everybody is not at the same place. So equity would definitely be sort of more tailored. In communities that have more needs, more resources need to be put in those communities. And communities with less needs have less resources so that everybody can be brought to the same level. So that's what equity means in sort of very late terms.
So much of the research, is it clinical research or basic science, or do you deal, because obviously the conference is for everybody, but do we address some of the, I guess, philosophical issues of health equity in terms of should we even have a health disparities conference? Should we even be concerned about things like that?
I think we should, because if we don't, then the issue gets buried. So I think we need to bring the attention of the problem to bear. However, that should not be the focus. That's not where we stop. So that's what we're saying. We're going from disparity to equity. We feel that everybody is aware. If you go to communities and you want to work with communities and all you do is talk about the problems, they'll tell you, yes, we know we got these problems, but what are you doing about it, or what do you bring to the table that takes us out of this predicament that we're in? So we're saying, yes, we have disparities, and we've been talking about it for so long, but how do we move the needle from disparity to equity? So that should be our next challenge. And it's going to take some very innovative ideas. I think there needs to be some paradigm shift, because you see, if you ask the same question and you tackle the same questions with the same tools, you're going to get the same results. And evidently the results we're getting is not getting us the full solution. So we got to think differently. Biology alone doesn't explain human problems. We got to deal with the social, the culture, the psychological, the emotional aspects of the human being. There are even issues related to spirituality that needs to come to bear. So the scientists, the biologists needs to be talking to the sociologists, need to be talking to the psychologists, need to be talking to folks in theology, and together in a very multi and transdisciplinary way, we can then begin to solve the problem, because human beings are complex beings. We're not just cells and, I mean, we're not just pure biology. And I think the old model of using the biomedical model has not worked. So that's why we now hear a lot of buzz about social determinants of health, because initially it was said to be, this is weak science, this is, it's very subjective. But human beings are just not biology. There's more to us than just bones, cells, blood, and water. So there are more dimensions to us, and all of that has to come to play if we're going to move the human race to a better place.
Well, you're a biostatistician by training, PhD in that area. So from your standpoint, and an international standpoint, because you're from
Ghana originally. Okay. Yeah, I'm a native of Ghana.
Very little accent, all right. But so, but from that point, looking at the numbers particularly, and if we just look at the numbers, if the goal is moving the numbers, then I agree. Then we have to look at it from a broader context, right, because the numbers won't move right, just on turning one dial. We have to turn more dials. So the next question then becomes, how broad can the research be? I mean, we're hearing our presidential candidates who are jumping over each other now, speaking about the social determinants of life and health in the African American community. We just happen to be in this political season right now. But healthcare shouldn't be swayed by those things, but obviously there's opportunity.
I think so. I think there's opportunity to revisit our whole healthcare system. My just personal take is that I think that the way we've contextualized health in this nation, it follows a different model. So I think a lot, personally, I think, deals with a lot of the market forces as opposed to some other developing countries where it seems more of as a right versus as a privilege. So I think that we would need to step back and really look at it, because a nation is strong. Its strength depends heavily on its health. So if your people are not healthy, you can't expect to get much out of them. So I think it makes even business sense to have a healthy population, because then they're more productive, there'll be less sick days, and people would give their optimum in terms of on the job. But when people are not feeling good, you're not going to get the best out of them. So to me, I think it makes business sense even to think about investing in the health of the people, because everything hinges on that.
Well, and I guess that's the thing, to have a health equity, health disparities conference. This particular institution is making a positive statement to say that we want to change the current environment, health environment. But obviously there are those who profit and who desire the current environment, who have, who in fact, I would say, may not have any problems with the disparities.
Well, that's
traditionally
true.
In America.
Well, that's true. I think it's like the coin on one side is the problem, on the other side is the opportunity. So in every situation, no matter how good or bad it is, somebody profits by it. But I think the profit is short-lived. So, I think that those who may profit may just be short-term, because eventually, without a healthy community, there's not much as a nation you can do. And eventually you lose your seat as a supreme nation. So I think to me, I think that people are profiting because of disparities. I think it's short-lived. But I think from a humanistic standpoint, I think it is our right as humans to make sure that every human at least have an equitable standard of living.
Wonderful. That's good. All right. So the research, the day-to-day activities of the center, how the center is moving, even when we're dealing with basic research, it has the potential, by the fact that we're dealing with health disparities, to affect policy, laws, philosophies, or affect every area of the university or any university. Truth just shakes things up.
Well, yes, I think that is the case. But I think what has happened, and the reason why we haven't maybe derived more from the research we do, is because, again, we're using the silo model. I think that the researchers who are doing clinical work, the pure science, need to be talking to people in the social sciences. We need to be engaging people in communication so that we can frame the messages such that people are able to take that knowledge and modify behavior. We know that knowledge gain alone is not enough to modify behavior. I'm reminded of a story of a friend. It's not actually a story, but a colleague of mine was telling me that she had a cousin, and the cousin basically had diabetes. But she was a lady who was very, very particular about her fingers, and she could not see herself live without those fingers. She wasn't doing anything to address her diabetes. So one day, this colleague of mine, in conversation with her cousin, said, you know what? If you don't take care of the diabetes, those beautiful fingers of yours, you're going to lose them one day. Immediately, that resonated. And she started to change everything that she was doing wrong and started to pay attention to managing her diabetes. So this is the power of language, communication, finding ways where we can take the knowledge we have, package it in a way that it resonates with the affected so that they can begin to modify. We're not doing much in that area. We're hoping that by us collaborating and by us coming together and dialoguing, whether we're scientists, whether we're social scientists, political scientists, that we come together, and community, we can't leave community out. Most times, you know, we do things and we never consult the folks in the community. So we need to all be sitting at the table to find out how we can then take the research we've done in the labs, in our clinics, and translate it such that the folks who are affected in the community would embrace it and then begin to change.
The candidate, Hillary Clinton and Bernie Sanders, both spoke about mass incarceration the other night and the issues in the African American community, young African American males. And there's a movement that mass incarceration is a public health issue.
Right, it is.
It's a part of the health disparity issue.
Right.
And in fact, if everybody's in jail, you know, it's hard to create families. Right. Well, by bringing in health professionals, does that bring the recognition that health professionals have to connect with one another if they're just dealing with cholesterol, if they're dealing with diabetes? How can we deal with diabetes if we're not concerned with the environment that a person is in? How can we be concerned about the foods that they're eating if we're not concerned about the stressors and things that they're handling?
So, and I agree. I think some of it has to do with the fact that we're not talking to each other. So I think that people who are good in advocacy, but I think some of these issues is that it's not that we don't know the truth or we don't know the answers. We just don't have the political will to bring about the change. So the example I like to give with disparities, and some of this has happened in Europe, where some folks who have two and three jobs are not going to stay home and cook for an hour. They're going to go to McDonald's and Burger King and the fast food restaurants because for them that's a quick way to get the meal. So if we know that trans fat is going to clog your arteries and it's going to cause you to get stroke and heart attacks, why can't we regulate the kind of oils that are used to cook these foods? As opposed to saying don't go to McDonald's when the person really feels they don't have much of a choice because they got 2-3 jobs and they don't have enough time to go home and do groceries and then cook a home cooked meal. So I think it comes down to political will. We sometimes don't have the political will. But also too, I think researchers have to arm those who would be willing to advocate for those things, to have the right kind of data and tools. We sometimes do great research, publish it, and it collects dust in those shelves in the library, and that's about it. So I think there needs to be a broader communication in terms of the spectrum so that folks doing the research are talking to, policymakers, people in advocacy, so that the results of the research eventually trickles down and actually impacts and brings about change in our communities. So I think it's not that sometimes we don't know. I think we have enough information. Sometimes we're not willing to act on it. And it may go back to the issue is that some people may not profit by the solution. So therefore, they let the problem persist. I mean, data, you ask about being a biostatistician and the numbers. I mean, there's clear evidence that if a kid cannot read by 3rd grade, or I think it's 3rd grade, the likelihood that that kid would not graduate from high school is very high. And if they don't graduate from high school, the probability that they will be incarcerated is very high. So if we know all of this, and as a very wealthy nation, why are we not mitigating, making sure that every kid can read by 3rd grade and 4th grade? You know, we don't have to wait till they drop out before we try to solve a problem. We have to use an upstream approach. And the story that comes to mind was there were 2 gentlemen who were fishing, and they saw a baby floating. So one guy jumped in and told his other friend to help him. And so they got in, and once they took that one baby out, another baby started coming. And so then the 3rd baby. So then the other guy jumped out and started running. And he said, "Where are you going? You need to be here with me." He says, "No, I have to go upstream and stop the person throwing the babies in the river in the first place." So sometimes we have to go upstream and solve the problem there, because if we're trying to do it downstream, it's just too late, and it's hard to come up with a solution.
Well, let me see if I can roll that down. The clinician in the room with the patient constantly is checking people's blood pressure, and everybody's 200 over 100.
Right.
Everybody,
Right.
is blowing the machine up,
Right.
over and over again. That health professional has a responsibility to go upstream
Right.
and vote or go to the state legislature
Right.
or the federal government or somewhere to say, wait a minute, we have policies that are literally driving these people
Right.
to early death.
Right. And maybe we should change the policy upstream, and then by changing the policy, we can decrease.
Okay, now, so people coming to this conference, then it's broad. Just no matter what they're listening to, whether it be activists or health professionals or whoever it is, it appears to me it's science and just general information, but it comes with the moral commitment of recognizing our responsibility to humanity.
Right, I think so. It's well said.
That was a question.
Oh, that was a question. Yeah, so agreeing, basically it's a question, but I'm saying yes, you're right.
All right, good. I'm joking, but yeah.
Right. I think it's, I think to solve health problems and to close the health disparity gap, I would be remiss if I don't underscore this. It's going to take both personal and societal responsibility. As individuals, we have to become responsible for our own well-being. However, we need the societal responsibility to put the infrastructure, the policies, to have the political will to put certain infrastructures in place to ensure that once my personal responsibility is engaged, that there's a support mechanism on the social level, on the societal level, so that I'll be able to do this. I mean, if I want to go and walk in my park close by, but the park is not safe, I'm not going to walk. And I know by walking, I may reduce my stress. I may be able to manage my blood pressure well, or my blood glucose if I'm diabetic. But if I can't go and walk because my neighborhood is not safe, then that becomes a societal responsibility. I have the personal responsibility and desire to do the right thing, to manage the disease, but I don't have the societal support or infrastructure in place.
But going back to the numbers, we just have a few more minutes though, but the role of a health professional,
Right.
Would you agree that it obligates them to go upstream? And if the numbers are solid enough to dictate that,
Right.
as you say, to arm them,
Right.
then we should have an army of health professionals that no matter whether they could care less about African Americans or minorities or not, because of their oath,
Right.
being a doctor, nurse, or whoever, they should be pushing this.
I think so, but I don't think we should limit it only to just the clinicians. I think the researchers have an obligation also to be able to make sure that their research doesn't just win an award in the discipline that they're in, but to see to it that the results gets translated into a state where it impacts the community that's affected. I think then we'll be making headways.
Then that is profound, because what that's saying is that the researcher has the ability to give better armor and a more powerful arsenal to the community than anybody else.
That's it. Yeah,
choosing their research and how they publish it and how they present it to bring it to the community.
Right. Eventually, it's got to be translated to where the community can make use of it. Yeah.
It's a moral commitment.
Right. I think so.
An ethical commitment.
I think it's ethical and moral. I think so, especially depending on the field that they're in, because certain fields require certain oath, and saying you would but okay. So even going back, and I think with researchers, when you go to a community and you recruit participants to partake in your study.
Wow.
You're saying that I want you to give of yourself so that we can learn about this issue and come up with solutions that even if it doesn't directly benefit you, it may benefit the generation after. So if we don't carry the message down such that it then changes the situation, then we have failed the folks.
That's good stuff. All right. February the 29th through March the 2nd, the Sheraton, not Xavier, the Sheraton, but it's sponsored by Xavier University College of Pharmacy, the 9th Health Disparities Conference. You can go online, Google it or whatever gadget you have. I mean, you can find it. Just go look for it. It'll be the Health Disparities, Xavier, put all those things in there. Please come. You will learn. Activists, all health professionals, some kind of way, stop in. But February the 20th, they can go online right now and get there, and social media. They can find it on Facebook and Twitter and Snapchat and all of that kind of stuff. Be ready to go. And who's the conference speaker?
This year, one of the, we have several heavyweights, but to highlight just one of them who is going to be the keynote for the John Ruffin Health Disparity Lecture is Dr. David Satcher, who is the 16th Surgeon General. He's currently in Atlanta, Georgia, Morehouse School of Medicine. I think he would be a delight for us, and we hope that people can come. It's during the luncheon time. So we welcome everybody to come.
Hey, Dr. Daniel Sarpong, awesome man. We're excited about what's going on at Xavier. Fight as hard as you can. Hey, kudos to Dr. Kathleen Kennedy and the entire team over there. Keep doing a great job. But let's be a part so we can be serious in our fight. Thank you so much.
Thank you.
Great.